Welcome back everybody, David here again with Med School Boot Camp. So in this next video, we're going to talk about loop diuretics. And you guessed it, loop diuretics act at the loop of Henle, specifically the thick loop of Henle. And if you recall, the loop of Henle is composed of two components, the descending loop of Henle and the ascending loop of Henle that goes back up. So it's really this portion of the nephron that we're focusing on when we talk about loop diuretics, because that is the primary site of the NKCC channel. Now, when we talk about the mechanism here, first we need to be familiar with some of the names that can be used in a question stem, right? So the most common one that you've probably heard of before is furosemide. However, torsemide, bumetanide, and ethacrynic acid are also ones that they will like you to know as well. Just keep in mind that most of these medications end in "ide," right? So if you associate that ending in the word with it being a loop diuretic, then it's kind of a helpful way to remember all the different types. One of the exceptions to that is ethacrynic acid. We'll talk a little bit more about that medication and when we might use that in favor of something else like furosemide later on. So when we think about the mechanism here, we said that it inhibits the NKCC channel. The NKCC channel is an abbreviation for a sodium molecule, a potassium molecule, and two chloride molecules. So that is why it's a CC. It's two C's for the 2-chloride. And this is a type of co-transporter. And what that means is that it brings the molecules in the same direction versus a counter-transporter would bring them in opposite direction. So you can see right here, the sodium, the potassium, and the chloride are all going into the cell through the NKCC channel. Now, recall from previous videos, what is water going to do? That's right. It's typically going to follow sodium. So as we talked about previously, the principle of osmosis tells us that water is going to flow from low concentration to high concentration. So we often think about this as the fact in the kidneys, water is going to follow sodium. So if we block this channel, if we block the NKCC channel, we're going to have more sodium that remains in the tubule. And what's this going to do to water? That's right. Less of the water is going to leave into the cell. More of the water is going to stay in the tubule itself, ultimately leading to increased diuresis in the patient. And so another way of saying this is that we decrease our interstitial tonicity. Because recall, typically substances are absorbed from the tubule into the cell, into the bloodstream, and the interstitium. But if we decrease that tonicity, or we keep more solutes in the tubule itself, that is going to increase our urine output. Again, because of the principle of osmosis. By keeping more solute in the tubule, and thus more water in the tubule, we're going to offload more urine. We're going to inhibit the kidney's ability to concentrate that urine. And that's one of the primary goals of using these loop diuretics. Now, we have to think about some other things here as well, as this can actually be a fairly advanced mechanism. So we say that we have a decreased potassium backleak into the lumen. So if we look at our potassium channel right here, we talked about in the nephron transporter section how the act of sodium and potassium coming across right here creates a concentration gradient and a charge gradient that actually pushes potassium through its cell. So if a bunch of potassium is building up in the cell, if the NKCC channel is working, well, that's going to push other potassiums out of the cell. And so when this potassium comes in, it essentially tries to push another potassium out. It essentially says, hey, there's not enough room for the both of us. You've got to leave. And that's what typically happens. However, if we inhibit this channel with a loop diuretic, this process is essentially lost. So we're going to lose this backleak of potassium into the lumen itself. And that's a problem for a couple of reasons. Because losing this potassium backleak results in decreased our calcium and magnesium reabsorption as well. Remember these molecules up here that typically would go through the cell paracellularly. Remember, they do not go transcellularly. They're too large of molecules. They go paracellularly, meaning they go between the cells. And the reason they are able to go between the cells typically is because potassium is backleaking into the lumen. This is creating a very positive gradient, a positive charge. And recall from basic magnetism that like repels like. So two positive charges are going to actually repel each other. And so potassium leaking out puts a bunch of positive charges in the lumen, which allows this process to occur. It allows for the magnesium and the calcium to transport paracellularly. Again, if we lose our potassium backleak, which we do if we inhibit the NKCC, we're losing this process as well. We're losing the ability to reabsorb magnesium and calcium. Now, this can get a little bit confusing, so just to summarize here, if we inhibit the NKCC channel with a loop diuretic, we block potassium coming into the cell. If we block potassium coming into the cell, we block the leakiness or the backwards flow of potassium out of the cell. Again, one potassium comes in, more or less says, there's not enough room for both of us, you've got to leave, potassium goes into the lumen. That potassium going into the lumen then leads to the electrochemical gradient that pushes magnesium and calcium through the cell. But if we lose that, if we lose this potassium going into the cell, we lose the ability of magnesium and calcium to be reabsorbed, and that's where we have a decreased reabsorption of these molecules. Now, additionally, more distal in the cell, we actually increase our sodium exchange for potassium and hydrogen in the collecting duct. We've talked about this again in the nephron transporter series in detail, but when we're not reabsorbing sodium earlier on in the kidney itself, if we don't reabsorb in the PCT, or the loop of Henle, the collecting duct is essentially the last effort that the body has to reabsorb our sodium. We don't typically want to lose our sodium. We want to retain it so we can retain our fluid and retain our volume status. However, if the collecting duct sees more sodium, it's going to act to actually retain it more at the cost of potassium and hydrogen ions. And so again, this kind of last-ditch effort to retain sodium in the collecting duct is going to be at the expense of secreting potassium and hydrogen ions into the tubules. And that is why we get the increased potassium and hydrogen excretion from the body. And as we previously mentioned, this is most commonly occurring at the thick ascending loop of Henle. Now, moving on to our clinical use. This is most commonly used in edematous states. What do I mean by that? I mean things such as decompensated congestive heart failure, pulmonary edema, or cirrhosis. The primary thing these have in common is that we're trying to offload fluid. These all have too much fluid in the body. We're seeing edema in the body for various reasons. And loop diuretics, one of their primary functions, by inhibiting the sodium coming back into the cell, we're going to have more water stay in the tubule. More water is going to be diuresed. We're going to have an increased urine output. Again, this is due to the principle of osmosis. More sodium remains in the tubule, more water is going to go into the tubule or remain in the tubule. We can excrete that from the body. And so the key point here is if you understand the physiology of what's going on, if you understand this nephron transporter, and then you understand what can happen if we inhibit that nephron transporter, the physiology essentially guides us into what pathologies we would use to treat. And that's really where I want you to be with this material before test day. I don't want you to have to remember the steps of the loop diuretics. I want you to understand which channel it inhibits and then be able to work backwards from there. Now, this can also be used for other conditions such as hypercalcemia, and this should make sense to us because of this mechanism we talked about, right? The decrease of the potassium back into the tubule decreases the reabsorption of our calcium and magnesium, which we talked about right here. And thus, for patients who have high levels of calcium, this can actually act to leave more calcium in the tubules, and thus more of it will be excreted from the body. And finally, the last one I want you to know for test day is that this can be used to treat hypertension. However, it's not a first-line agent. There's a lot of medications that can be used for hypertension. This is rarely, if ever, going to be the correct answer on a board question. However, we can think about this in the same context, right? If patients are volume overloaded and that's causing them to have high blood pressure, anything that decreases their volume status should inevitably lead to a decreased blood pressure overall. So something to be mindful of, unlikely to be the concept that they actually test on test day. They're more likely to focus on the hypercalcemia or the edematous states. Now, moving on to the adverse effects here. One of the classic ones they like to ask you about is ototoxicity. That is to say that some of these medications, some of these loop diuretics can actually damage the hair cells in the inner ear itself, leading to ototoxic effects. Really important and high yield one. They love to test about this one. They'll tell you about a patient who has heart failure, is recently started on furosemide, and now they're not able to hear quite as well during the clinical exam. This is a classic presentation of ototoxicity. Now, this can also cause some other things, including metabolic contraction alkalosis. So a couple key things I want to discuss here. One is that we're getting a contraction. So this is just saying essentially that our volume status is contracting. And this should make sense. Why? Because a loop diuretic is going to increase a patient's urine output. So overall, their volume status is going to decrease. It's going to contract is how I want you to think about it. The second thing is that this is a metabolic alkalosis. And why is that? Well, if you remember our equation, which tells us that carbon dioxide and water can form to create carbonic acid, which can then dissociate two protons in bicarbonate. Now, with patients on loop diuretics, what's happening to their hydrogen protons? Well, we mentioned that one of the things that can happen is that we increase the excretion of hydrogen protons. That is to say, they go down. And so when hydrogen protons go down, the relative amount of bicarbonate actually increases. When we talk about acid-base status, we're not always talking about total amount of acid in the body or total amount of bicarb in the body. We're talking about them relative to one another. We're talking about the ratios. Is there 3 times as much bicarbonate than hydrogen protons? Well, that's going to be an alkalotic state. So anytime there's an imbalance between hydrogen and bicarbonate, we're changing the pH in the body overall. So we said that hydrogen proton excretion increases and thus bicarbonate is relatively higher, and that is why we get the alkalotic state or the metabolic alkalosis, because bicarbonate is a metabolic product and the alkalosis because it's going to be elevated relative to our hydrogen protons. So altogether, we have a metabolic contraction alkalosis. Now, another adverse effect includes acute interstitial nephritis. This is most likely to be seen in our sulfa-containing loop diuretics. So that includes our furosemide, torsemide, and bumetanide. And essentially, this sulfa component can actually react in the body. It can create a little bit of a hypersensitivity reaction that can actually affect the kidney, leading to acute interstitial nephritis. Which leads us to our next point, in that if a patient has a sulfa allergy, we're going to consider using an ethacrynic acid. Now, ethacrynic acid is not our primary use for any patient, right? Because it has the increased risk of ototoxicity. We talked about that being a major adverse effect for a lot of these medications. So it's not our first line choice. But if a patient has a sulfa allergy, they're much more likely to have these type of hypersensitivity reactions, which can further damage the kidney. And that is when sulfa allergy will be the best choice. So be mindful of this. Be careful. They will give you a whole question stem. It's a slam dunk question. It's all about heart failure and the 2+ pitting edema. But somewhere in that question stem, they are going to mention that a patient has a sulfa allergy, and then they're going to expect you to choose ethicrinic acid as the correct answer. So don't just jump to furosemide because that's the one we're most familiar with. Make sure the question stem does not tell you there's a sulfa allergy. If it does, it changes the answer and it changes the question completely. And finally, the last one we're going to talk about here is electrolyte abnormalities. These should make sense to you based on the mechanism, right? You can get hypokalemia because we're increasing our excretion of potassium. You can get hypomagnesemia because we are decreasing our reabsorption or increasing our excretion of magnesium as well. You can get hyperuricemia for a similar reason. And finally, you can get hyperglycemia. Now, this one's a little bit unique. So if we think about the process of insulin release in our body, right? The pancreatic beta cells ultimately release insulin. Insulin then takes up the glucose into cells. But in these types of patients who are on loop diuretics, we basically deplete their potassium. We decrease their potassium system. So in our pancreatic beta cells, which I'm drawing here, we have this biochemical pathway which glucose enters the cell, ATP builds up, ATP then closes a channel which allows for potassium to build up inside the cell. Potassium building up inside the cell then opens up another channel which allows calcium to move through it. That calcium coming through the cell is then going to stimulate the release of insulin. And insulin, we know, can go out into the body, and this is going to allow us to activate our GLUT4 receptors and bring sugars into the cells. Now, if this process is blocked, right, if we have less potassium in the body, when ATP builds up and closes this channel, we'll still have some potassium in the cell, but maybe we'll only have 2 molecules instead of the 3 molecules we had before. And now that we have less potassium in the cell, because there's less potassium in the body, we don't have as much of a charge change to allow the calcium to come through, right? This channel might not open as readily, calcium might not come through, and thus it might not stimulate the release of insulin as much as it would previously. If we decrease the stimulation and release of insulin, what's that going to do with blood sugars in the body? That's right, they're going to be elevated. And that's why we can get a hyperglycemic state in patients who are on loop diuretics. So a very classic vignette for this medication might include something along the lines of a 75-year-old patient presents to the emergency department complaining of shortness of breath, difficulty breathing, as well as a lot of swelling and pain in their feet. They deny any fevers or chills or vomiting, but on physical exam, you notice that they have 2+ pitting edema bilaterally in their extremities. You hear a lot of wheezing and crackles on their lung exam. You review their medications and see they're taking things like ACE inhibitors and over-the-counter calcium supplements. You also note that they're allergic to penicillin, sulfa medications, and latex. And the question asks you, which of the following medications would you like to start this patient on? They're going to give you a variety of different options to choose from, including furosemide and some of the other loop diuretics. However, be mindful, this patient has a sulfa allergy. So we do not want to start them on furosemide. We want to start them on ethicrinic acid because of that little tidbit in the question that said, oh, hey, they also have an allergy to penicillins, sulfa, and latex. So be mindful of that. If they don't have those allergies, furosemide would be a very appropriate medication for this patient. So just in quick summary here, we're talking about loop diuretics. Basic things, right? Inhibition of the NKCC channel. This is short for sodium, potassium 2 chloride. This is going to ultimately increase our urine output through the principle of osmosis. More sodium in the tubule leads to more water staying in the tubule as well, more urine output. Now, we also have things like a decrease in potassium backleak. This is going to decrease the reabsorption of calcium and magnesium. We talked about that mechanism up here. And the increased sodium going distally into the collecting duct is going to increase our excretion of potassium and hydrogen. Recall, in a last-ditch effort to bring back our sodium, we are doing it at the expense of hydrogen protons and potassium. Leading into our clinical use, we have our edematous states, most likely one they'll test you on, also can be used for hypercalcemia, potentially can be used for hypertension, but less likely they'll test you on this mechanism. And as far as our adverse effects, I want most of these to make sense physiologically. The first of which is ototoxicity. Don't really need to understand the physiology behind this, just need to know that it is a known adverse effect. The ones I do want you to understand the physiology on are the metabolic contraction alkalosis. We talked about how we are decreasing their fluid status and we are increasing the bicarb relative to hydrogen protons, thus the metabolic alkalosis. We talked about acute interstitial nephritis, how some patients can have a hypersensitivity reaction to these medications. We talked about allergic reactions and how we want to use ethicrinic acid in a patient who has a sulfa allergy. And finally, we talked about the electrolyte abnormalities and how we can develop hypokalemia, hypomagnesemia, hyperuricemia, or hyperglycemia.